I'd like to first welcome all of you to the Atricure Lunch Symposium. My name is Ralph Damiano, and it's my real honor and privilege to moderate this session. I think we have some great speakers for you over this lunch. We'd like to keep it very informal. If you have any questions, I don't think any of our speakers would mind being interrupted. Because we're kind of running late, we are going to go till 12:45. Well, actually to 1:45, I should say. So we have plenty of time to get through the program. I was asked to give a talk on my journey to becoming an arrhythmia surgeon. I'm going to save that because of time constraints to near the end. I could almost just talk about it, but to say that journey involved some serendipity, some great mentorship, and a lot of hard work and a real love for the field. Which has really sustained me to when I joined Jim Cox's lab as a third-year medical student in 1979 up till now. And I would say that certainly the field of arrhythmia surgery remains one that I think is both tremendously exciting and also a great field for some of the young fellows and early stage surgeons, because there's as many unanswered questions and unknowns and huge areas of really, I think, important investigative research. And I think just like coronary disease, this field is going to be changing dramatically over the next decade. So it remains to be very, very exciting. I'll introduce our first speaker this afternoon is Dr. Richard Whitlock. He really needs no introduction. As many of you know, has been the PI of many of the really most important randomized studies in these areas. And he's going to speak to us this morning on left atrial appendage management, arrhythmia surgeries, Lima to LAD. Richard?
Great. Thanks so much, Ralph. So I was asked by the Congress to talk on left atrial appendage management during CABG, and then was also invited to give this symposium. And there's only so much you can say about left atrial appendage, I think. So it's a bit of a different talk today. I just want to highlight, we're going to discuss some of the evidence, but I want to highlight particularly to the trainees and the junior faculty that there's still some really low-hanging fruit of where we can advance in this. And I say this is arrhythmia surgeries Lima to LAD because we now have just a really strong evidence that patients with atrial fibrillation coming for cardiac surgery really must have their left atrial appendage managed in some way. I just want to start off with this, and for the senior or more, I'll call it ourselves, I think I'm one of them now, more experienced surgeons in the room, or in fact, just in life. It's human nature to think that the relationship between effort and reward or outcome is linear, y equals x. This is this blue line here. But that is simply a lie. I give a talk actually about once or twice a year with a friend of mine who is an Olympian, and he actually gives his talk first, and then I relate it back to my career both as a surgeon and as a researcher. The fact that you have this early period in your career or in your learning, or if you're starting to do minimally invasive cardiac surgery, where you're putting in a ton of effort and you're not actually seeing that much award, and you're going to have some ups and downs. And I'll show you a little bit in terms of my research path, how that is true. And then you suddenly hit an inflection point and things really start taking off. And the reason I say this, and I'll show you, reiterate at the end, is I think in arrhythmia surgery and improving our patient outcomes and uptake, we have hit that inflection point with data in terms of uptake, but in terms of how fast now the evidence is going to be coming in. And I'll demonstrate that very clearly to you. So we all know that atrial fibrillation is this lack of rhythm or disorganized rhythm of the upper chambers. You've got this like finger-like projection on the top of the heart that in 1948, Dr. Madden of the US suggested that managing this appendage could reduce the risk of thromboembolic events. And it really had not been answered in a robust manner since 1948 until around 2021. But the incredible thing is the outcome of these strokes or thromboembolic events. You must know that atrial fibrillation strokes are the worst type of stroke you can have. They're huge, often hemispheric. They're often not survivable, but if you survive, your life, the life of your loved one, the life of your patient, it's changed forever. This was the data really prior to LEOS 3. The cardiologists were leading this field in terms of percutaneous approaches with, this is on the Watchman device, Protect AF, Prevail. They wanted to prove that you could actually replace oral anticoagulation with a device and that it was a non-inferior procedure to warfarin. That's this top efficacy outcome here. This is a net efficacy looking at both bleeding events in the brain and ischemic events. If you look, up until we performed LEOS 3 with our surgical community, there was no evidence that managing the left atrial appendage reduced ischemic stroke. This individual patient meta-analysis of Protect AF and Prevail actually suggested that it was likely slightly worse than warfarin. It probably had some effect, but slightly worse than warfarin. Also, keep in mind, until LEOS 3, this data, when we do a sample size, it's not about the number of patients in your study. It's actually about the number of events that occur in your study. All of these conclusions in this industry and the FDA approval was launched off of 28 events. I will tell you that data is fragile. In LEOS 3, we had 268 events. And that's why the surgical data is so clean, is so robust, that if you are not managing the left atrial appendage in your patients who are coming for open heart surgery, you need to come out of the operating room and explain it to the intensivists, to the cardiologists. It should be now an expectation, and that is why every guideline says you should be doing this. So let me tell you again about a little bit of a pathway and bumps in the road. So LEOS 3 was not my first trial. I've actually have run and has been involved in many, many randomized trials. SIRS was my first trial. It was a medicine within surgery trial. It failed. We thought methylprednisolone was going to help patients on pump. It was 7,500 patients trial. I actually got this funded by the Canadian government as a resident, and then they had to figure out like Whitlock's a resident. One of my great mentors at the time, Kevin Teo, held the grant for a while until I became staff. But one of the important things about SIRS, even though it was kind of on that platform where I didn't hit inflection point yet and launch in terms of career, is I started building this huge network to do these type of clinical trials like LEOS 3, like LEAPS, like PRINCE that I'm doing with Mario Gaudino, like TRICS for transfusions. We established a huge network across all of our countries. And this is a very powerful thing because it can robustly answer with these large trials that compete with, or if not, are superior to the ones that our interventional and arrhythmia colleagues are putting out. So this trial was great, Lancet, it was negative, but it built the infrastructure in order to do LEOS 3. And LEOS 3 was an opportunistic study, really. Chest is open, appendage is in our way. LEOS 2 was actually a versus anticoagulation study. LEOS 3 was done on top of anticoagulation, and I actually liked that because it means that we never had any competition because that field's constantly shifting, and as the drugs get safer and maybe more effective, people will start saying, well, maybe we shouldn't take the appendage off. No. Whether they're on anticoagulation or not, you have a stroke reduction. So it's safe, it's easy to do, and it has a huge effect. In that trial, we allowed 3 techniques of left atrial appendage occlusion. We allowed a stapler occlusion, we allowed cut and sew, and we allowed a regulatory approved device, which was the AtriClip. I put this slide up here because I will show you that this becomes very important in where I think we need to go. We used that network that we'd established in SIRS and some other studies at that point, and we randomized 4,811 patients, 105 centers, 27 centers, and it was a home run. For your patient, this is a gift that keeps on giving. There is an early and ongoing divergence of the risk of stroke for your patients if you manage the appendage versus not. Not only that, these are huge strokes. The treatment arm still had some strokes, and people said, well, why was it 0? Well, because these patients have elevated CHA2DS2-VASc score. They've got carotid disease, they have hypertension. There are other sources of stroke. We have done subsequently and just published in JAMA Neurology an analysis that shows that if your patient, after you've managed the left atrial appendage, if your patient has a stroke, it is much smaller and it is more survivable than if you had not. You're eliminating the AF strokes or dramatically cutting AF strokes. So again, this was fantastic. It was great news. The editorial in New England Journal was that this is the closing argument for surgical left atrial appendage occlusion. I now say, and have a paper coming out that I'm writing for EJCTS. It's not yet closed because I think there's new frontiers in atrial cardiomyopathy, etc. But for atrial fibrillation, it's closed in a way. There are different ways of occluding the appendage. And I'm sorry, some suck. We have to be perfect at this. And this is why I say it's our Lima to LED. Like when you're doing your cabbage, it is what puts us ahead of PCI, right? So if you can sew a 1.5 or 2 millimeter Lima to a 1.5 or 2 millimeter LAD, I'm telling you, you can spend some extra time and make sure you do this well. So we know that closure from within is problematic. I do standalone mini mazes on patients where they've had failed ablations. I CT scan my patients. I try so hard with this technique and I still have failures. It's not perfect. In LAOS 1, we tested stapler. It leaves stumps. It's hard to get the stapler down to the base. We also tested like just a purse string around the base. It didn't work. We had leaks. We had stumps. Don't do that. Don't just do a lariat-like thing. It's not ideal. The best approaches to this are, number one, a cut and sew. Cut right down to smooth atrium, close it with a 3/4 proline, double layer linear closure. Your hole should be right onto your superior pulmonary vein on the left side. No trabeculation should be left behind. And the second thing is there's a lot of data around the AtriClip, a regulatory approved device. There's now other devices out there. As they come out and they prove efficacy over 95%, I think this has big implications for our field. I will tell you a story. In LAOS 3, I did a biobank. We had centers sending us their left atrial appendages so that we could do further testing, figure out what was triggering clots to form in the appendage, look for novel targets, et cetera, et cetera. From a few surgeons, I was getting these, and people have heard this before, these little tiny appendages, I thought. I'm like, wow, these are the smallest appendages I've ever seen. They said, oh, no. The surgeon's nervous about going down into the smooth atrium. They're just sending the tip, and they're just they're suturing it off and sending you the tip. This is all they're doing. I call it the left atrial appendage circumcision. If you circumcise your appendage, you will still have a stroke. You need to do it well. And with that, I will tell you, we have started a study in Scandinavian countries. We're CTing patients who have already had their appendage managed. We're looking at the success rate, and the success rate is sitting around 70 to 80%, depending on the center, with all sorts of different mechanisms of failure. That study is great. We'll tell you which techniques are going to be the best. I think this will be very informative. But I want you to think about this. We showed a 33% reduction in stroke in LAOS 3. Is there anybody, and we told people do a TE and make sure your appendage is occluded properly. Okay? Is there anybody in a room who thinks that we got 100%, based on my circumcision story, 100% successful occlusion of all appendages in the treatment group? I would guesstimate actually the trial probably had between 70 and 75% success of occlusion. I'll bet you that there was somewhere between 25 and 30% where we left stumps that were too big. We didn't put the clip on properly. We didn't get the stapler down to the base, stuff like this. I'm sure it's around 30%. If one assumes a linear relationship, and here are some assumptions, and I just want to show you why I think this is so important. If one assumes a linear relationship between the success of left atrial appendage occlusion and stroke prevention, and it was 70% success in LAOS 3, I'm guessing. If we had a 33% reduction, then for every 1% of a successful occlusion, you get about a 0.47% reduction in the risk of stroke. So if you now look at the other numbers, so let's see if we can get up to 80% successful by being really careful with cut and sew, stuff like this. That would actually translate into, instead of a 33% reduction, a 38% reduction. If you get to 90%, which is cut and sew, which is Atricure, we're talking about a 42% reduction. If we can get to 100%, where you really spend your time, you don't mess around, you do this for all your patients, you will have nearly a 50% reduction in stroke. That competes with any medication that you can give to your patient. So take your time, be aware of the techniques that work, and treat this like your Lima to LED. So last thing is, again, that whole concept of y equals x to the power of 2 is which I showed that curve. This field started with a great idea in 1948. I want you look at this timeline. It went from the 40s to the 2020s. 2021, May, is when we had Laos 3, when we had the robust. That was 5 decades. It was very slow, but we have hit an inflection point. I know there's uptake of this. Look at us now. LEAPS started 2023. We recruited in 2 years, 606 business days, 6,573 patients. We have started a new trial, BOX-NOIF, prophylactic ablation in atrial cardiomyopathy patients with clipping. It is recruiting like wildfire. The next 3 years, we are going to see an insurgence of evidence like you have never seen before in surgery in terms of leading to Class 1 recommendations and having meaningful impact on patients. Thank you so much.
We do have a few minutes. Does anyone have any questions for Richard? Maybe I'll ask you one quick one. What do you do for occlusion of your appendage, both in a sternotomy case and also minimally invasive?
Yeah, so sternotomy, again, so I'm in the Canadian healthcare system. There are cost constraints, right? So I would say right at this time, it is 50-50 between amputating and closing and clipping. There are certain patients I don't like to open the heart if I don't have to. CABG patients, man, like when I used to only do cut and sew, you open it, you're coming off pump, you got the air in the heart, it goes down your RCA graft, you're going back on. Also, all the air going other places. I think that we have a lot of micro hits in life. Going to the brain, stuff like this. It's probably not great. If I can keep it a closed chamber procedure, I think that's ideal. Fragile tissues, I don't want to cut and sew. Really long procedures. The Atricure takes me about 6 to 10 seconds now. It's so fast to bang on a Flex V. Cut and sew is excellent. I can do it in like 4 minutes. It works fantastic. If there's thrombus in the appendage, I'm doing that. If it's a shorter procedure, I'm already in the heart, I do cut and sew. So those are my 2 go-tos.
Okay.
Minimally invasive. Yeah. So when I'm doing my mini mitrals or I don't do mini CABG, I'm not talented enough in CABG, but mini mitrals, mini maze, if I'm able, you often can get through transverse sinus, you can get a clip through that way. If they've been in there 4 times before trying to do ablations, I find the appendage is actually stuck down onto the left side veins. I struggle to actually free it up and get a clip on in a safe manner. In that case, I close from within and I follow those patients up. I say I have somewhere between 80 and 85% failure rate, even though I try really hard to make them sure I see the whole ostium, double layer, linear closure. There's a failure rate that I can't seem to overcome in that.
Yeah, I would agree with that. That's also my practice. But I also would say another option on the minimally invasive would be the pericardial patch. And
yes,
some people now reporting some reasonable results. I don't use it, but it is another.
Yeah, it shouldn't be overly prothrombotic. I'm sure but yeah, so. I think that, but these are areas where these are wrought for study for early investigators, right? Like, just show that through case series that, hey, with this technique on minimally invasive procedure, we can achieve a 96% success rate. So,
yeah. Thank you, Richard. Great talk. We'll move to our next speaker, Dr. Ken Cooey, who is joining us from Cedars-Sinai, and a real pioneer in developing new techniques for treating atrial fibrillation surgically, is going to talk to us about a stepwise approach to ablation in CABG patients.
Great. Good afternoon. Ralph, thank you for the introduction. Thank you for the ICC and Atricure for sponsoring this luncheon. So as you heard, and as kind of Richard spoke about earlier, we understand that there is a learning curve with treating atrial fibrillation, whether it's just the left atrial appendage or whether it's the surgical ablation component. So what we've tried to construct, or what I've tried to construct here, is really a stepwise approach. So starting really from square one. So here's my disclosure. So let's just put it in a framework that I think most people can understand, which is kind of this baseball analogy. So the thought is, start with base hits. Don't swing for the home runs. And really, when you think about treatment of atrial fibrillation in a simplified way, it's really about reduction in critical mass of left or right atrial tissue, and then the reduction of stroke that Dr. Whitlock just spoke about. So let's start with that Toronto Blue Jays single, right? Over and over and over again. So that's the left atrial appendage management. That's your AtriClip. Dr. Whitlock just showed us the compelling data, the class 1 recommendation. So here's just a couple tips and tricks on how to get that 100% occlusion rate that Dr. Whitlock just spoke to. So the first thing is, we're all here, we're all familiar with how to expose this portion of the heart, but I think typically what happens is when we're exposing, let's say, a ramus or a high OM for coronary surgery, the typical move, at least what I was taught, right, you lift up the heart, you pull the apex up towards the right shoulder. If that's the move you're going to use to expose the base of the left atrial appendage, unfortunately what happens is you often compress that area where the left PA and the base of the left atrial appendage and the pulmonary veins exist. So it's often better to get better exposure of the base of the left atrial appendage by pulling that heart down towards the right hip. So if you have an assistant, a medical student, somebody next to you who can hold the heart in that position, that's going to optimize the exposure in that space. Next, realize these are some videos from a beating heart in an MIS ablation case. The base of the left atrial appendage tends to be horizontal and tends to exist within the transverse sinus. So when you apply your AtriClip, that AtriClip should sit horizontally and flush with the dome of the left atrium. So a really easy way to see if you're really capturing that orientation appropriately is just to look at your post-op day 1 chest x-ray. So the first picture is a patient that I recently did with a sternotomy, right? You can still see the swan, the wires, the sternal plate. You see the AtriClip oriented horizontally. For those of you who are doing right MIS work, again, going through the transverse sinus like Dr. Whitlock just mentioned, the clip can still sit horizontally in that transverse sinus and get the entire base. And then for all the left MIS surgeons, right, you just saw a patient from Gianluca this morning with the robotic CABG. If that patient has AFib and you're managing the left atrial appendage, again, look at that post-op 1-day chest x-ray. See if that clip is indeed horizontal. Okay, so you've knocked out your single. Now you're going for your double. I think in this day and age, modifying that substrate, reducing that critical mass of the atrium, really the biggest kind of bang for our buck right now is with that Encompass clamp, right? How many of you, just by raise of hands, have used the Encompass clamp? So maybe about a third to a half. Okay, so the Encompass clamp is a radiofrequency clamp. It's designed to get all the way around the posterior left atrium as a single instrument, and it's guided with red rubbers. The key to it is when you guide the clamp around, the clamp has to go anterior to the pulmonary veins, but it needs access to that posterior wall, right? So you have to go through the oblique sinus between the IVC and the right inferior pulmonary vein, and the space underneath the SVC to gain access to the roof, or that neotransverse sinus. When you use the Encompass clamp, it's super important to make a wide berth of that space or of those sinuses. So when you develop the oblique sinus in these patients, please do it quite widely. It's going to make the passing of that clamp so much easier. And when you do that over by the SVC, you don't need to be up by the RPA. I think sometimes we get concerned that we're going to injure the RPA. You can simply be between the dome of the left atrium and the RPA. Just go into that little fat pad right there, score that, then grab your finger and just come around the SVC if you're concerned about the RPA or any of those structures. Then you can pass your red guide around. And for those who have not used it, this is what it looks like. And for those of you who haven't done this in a while, that's a sternotomy. Patient is on pump. This has to be done on pump. The guides are placed, like I said, through the sinuses. The clamp is introduced into the sternum parallel to the sternotomy. You just simply use the guide to bring the clamp into the mediastinum. You relax the clamp so it just kind of passively opens. You can orient the clamp towards the left shoulder, because again, that's kind of the natural path of those sinuses. I then grab my suction, my yank hour, and I check to make sure that the tips of the clamp are indeed tracking to the sinuses. And then I just use the guide to make sure there's no resistance, and I pull the guide, and that just tracks the clamp into place. And now what you have is this entire clamp is anterior to both sets of pulmonary veins, and it'll create a circumferential lesion that completely isolates that posterior wall. So the critical steps: before you ablate, you want to have your echocardiographer pull back the echo, right? You don't want the echo stenting up that esophagus against the back of that clamp. You want to make sure that your left atrial appendage is medial to the clamp, so you're not burning right on the left atrial appendage. You can turn your root vent on if you have it on. Then go ahead and clamp. And you do want to lift up on the clamp ever so much just to create some space between the clamp and that posterior pericardium. And then you can suction back there just to keep it dry so you don't have any extra fluid back there in the clamp. This clamp is more robust. It creates a bigger lesion. It does take a little bit more time because there's more tissue. And so what we're recommending is that you perform at least 3 transmural ablations. What does that mean? That means you apply the clamp, you hit the button, the foot pedal, and it'll go through the algorithm. Sometimes it'll go through it a couple times before it gets completely transmural or gives you that transmural section. Once you're done with that, do that 2 more times for at least a minimum of 3. And if you're just starting out, what's a nice trick to do is test your pulmonary veins to make sure they're actually quiet when you're done. You can either use a DeBakey and alligator clips, you can use a sensing pen, you can use whatever you'd like, and we can go over more of that kind of offline in detail, but it's a really nice way to confirm that you've actually completed an entire box. Then at the end, I always irrigate the back of the pericardium. If it's become warm at all, I just kind of cool it down, and then we talked about that. How long does this take? So we published a paper looking at this technique and its success rate. It took the difference between adding the Encompass ablation and a clip to a patient who was just getting a clip was 12 minutes. So 12 minutes of bypass time, no additional cross-clamp time. So a typical case, let's just walk through: full sternotomy, central aortic, two-stage right atrial venous. I do my standard route. I initiate cardiopulmonary bypass, develop the sinuses, go through those steps we just spoke about. Then I cross-clamp, arrest, clip the left atrial appendage, and move on with my index surgery. That's kind of the typical flow of a case for me. All right, so you've hit your double. Moving on to our triple, right? So the additional components of a Cox-Maze to achieve the best outcomes for treating atrial fibrillation involve additional substrate. And typically that includes the mitral isthmus. That would kind of be the next natural thing that you would want to achieve. And classically, there's been some resistance to this because it requires opening the left atrium. Our colleagues, Dr. Sherman and Dr. McCarty down in Florida and Tampa came up with, working with Dr. Cox, a kind of a novel approach to create this additional substrate ablation, this mitral isthmus, and they called it the Tampa 2. And so here they are working in the lab with some voltage maps, figuring out how to do this. So just to kind of, to bring everybody on the same page. So we've opened, this is just a diagram. You've opened the left atrium, and there's your Encompass ablation, right? That's what we just did with the Encompass clamp. This whole area, and again, think about it kind of in a 3D circumferential manner, is the mitral isthmus. That would be the next natural area that you would like to ablate. And there's that Coumadin ridge. That's the area between the base of the left atrial appendage kind of down to those left pulmonary veins. That's kind of all the substrate that's available that we typically address during the left-sided lesions of a Cox-Maze. So again, classically, we would do this through a left atriotomy. We would take a cryoprobe and pass it from the cut edge of the left atriotomy onto the mitral, and then we would take either an RF and go from the Coumadin ridge down into the left pulmonary veins. But again, that would require a left atriotomy. So what Kevin and Andy did is they said, well, what if we take the mitral isthmus and instead of placing it here through a left atriotomy, let's just place the cryoprobe through an opening in the left atrial appendage onto the mitral annulus here. It addresses that same swath of tissue without going through a left atriotomy. So there's your mitral isthmus line, and then naturally the next line would still be the Coumadin ridge, and again, let's do that through the base of the left atrial appendage onto the left superior pulmonary vein. So electrophysiologically, you've created the same lesion set as your left atrial lesion set from the classic Cox-Maze, but now you've done it through the left atrial appendage without opening the left atrium. And they confirm this, and so for those of you who are familiar, this is a voltage map. Here is the mitral annulus, and coming through the appendage, they created this beautiful block. Gray is dead, gray is blocked out, a really beautiful mitral isthmus line. Okay, so now you've hit your triple, you're ready, you're swinging for the fences, you want to hit that home run. So I'll tell you kind of my version of the home run right now. So yes, bicable cannulation. I'll use the Encompass clamp, beating heart, not arrested. Then I'll do my right atriotomy and I'll do my right-sided lesion sets. And then I'll add that Tampa 2 and I'll clip the left atrial appendage. Takes about 30 minutes to do a full kind of biatrial maze. Now, this was recently presented at the STS, not to present competing coronary data, but this was from Dr. Rushing and his group out of remind me. University Hospitals Cleveland, sorry, just, that was one of those micro moments you were talking about, Richard. Yeah. So using those fundamental kind of ideas of using an Encompass clamp, non-atriotomy, using the cryoprobe to get into the mitral isthmus and the left atrial appendage, adding the right-sided lesion sets, taking that kind of in total, and then following those patients with appropriate monitoring, what Dr. Rushing and his colleagues were able to show is a really high degree of success. Again, small series, because these techniques are just still being introduced, but 1 year freedom from atrial fibrillation, atrial tachycardia per HRS guidelines, 96% success. 2 years, so this was sustained. 16 of those patients have now had 2-year follow-up, 96% success. And it's really important to see that this was a very kind of disease advanced population with over 50% having non-paroxysmal AFib and really 40% having that long continuous more than a year of AFib. So really, with these new introductions, we can still get the same results that we've classically seen with the biatrial Cox maze. So in summary, I hope this provides at least some sort of framework for a stepwise progression of the treatment of AFib. Step 1, clip that left atrial appendage. Maybe your first 5 cases, if you've never treated an AFib patient before, get through that, make sure you can orchestrate smoothly how that component is going to fit into your CABG. Are you going to do it at the beginning? Are you going to do it at the end? Are you going to do it before your distal? Are you going to do it after your distal? Sort that all out in your mind so it's smooth for you. Then your next 5 cases, do the clip and add an encompass. 10 cases in, you're doing a tremendous amount of positive treatment for this patient. Give that 10 cases to kind of marinate. Then your next 5 cases, add your Tampa 2. And I think really at that point, you're adding your right atrial lesion set and 20 cases in. For this audience, that's probably, 2 weeks of CABGs? If you have 2 weeks of CABGs with AFib, I bet 20 cases in, you could be very smoothly doing biatrial mazes and reducing that critical mass, reducing the stroke, and significantly helping your patients. So thank you so much for your attention. There's my email if you ever want to chat AFib. Thank you.
We've got some time. Any questions practically for Dr. Kankui, how he does this? And anybody? Yeah, go ahead.
Yeah, I think that's a great point. It is a bit of a blind maneuver, right? So the take home is you're just aiming for that LV apex. You know what's going to cross the mitral valve, and it's about kind of pulling almost laterally after you pass the mitral safely. It's just about pulling laterally and really, make sure you've effaced that probe completely on that lateral wall. But yeah. I mean, I guess if you knew ahead of time, you could pull out the endoscope if someone's taking endoradial or endovein and looking, but you could do that. Great question.
Yeah.
My question is, if you're doing beating heart surgery, how do you
So I know Dr. Puskas, are you, no, he's actually moderating
Went the
next
other
door.
session.
He has a nice video on how to use the encompass on beating heart, so off pump. Essentially, the idea is you want to create partial occlusion. So you want to make sure the encompass is not completely around the entire left atrium, because then you'll obviously get rid of all your preload. So you want to pull that encompass clamp back a little bit so at least the other side of veins is open. And so you would go from the right, do a partial encompass, if you will, and then you rotate it, come from the left, do a partial encompass. So you maintain partial preload either time, and then you have a complete box.
Yeah, but you'd have to be through a sternotomy for
Yes.
that, for sure.
For now.
And that's not for that's very early in development.
And the technologies may change with new energy sources coming, right? PFA, what I'm hoping is if we get PFA into the encompass clamp, it's literally, you could close it for a second, zap, open it, and do that a few times. Obviously, need to be studies in terms of transdermality. I mean, just before Mark goes, do you, when you're with your encompass clamp, are you developing Sondergaard groove at all to take some of the fat off to make sure you've got a good exposure on that surface?
Yeah, that's a great question. So that intraatrial groove, as we all know, will have fat in it typically. I think what's important is at least to score that kind of cellular layer so the fat splits. There is a difference when you use the encompass clamp and you've at least scored that. You'll see the right atrium kind of just migrates, kind of just lifts off that left atrium. And so I think you can get more antral. You can actually get onto the left atrium more. So if you're comfortable, just kind of score that at least. If you're, a comfortable mitral surgeon, the more of that you take, the larger your box will be, I think, the better.
Mark?
Hey, thank you. Thank you, Ralph. Mark Bell from Ottawa. Great talk. Coming back to your previous comment, I think this is an industry symposium and we have our work cut out for ourselves together, right? Because I think when we can achieve this minimal invasively, say, we always compare PCI to CABG or TAVR to SAVR, but let's remember, we surgeons can offer combination therapies as well, right? Left atrial appendage, plus a mixed CABG, plus an AF ablation. Imagine that. It's not easy for our colleagues in cardiology to do that as effectively and as together as we can offer it. So I think there's huge opportunity here. I would love to be able to do this off pump. I never do a CABG on pump. And I would even love more to be able to do this through a small left thoracotomy. Like Ferdy has done a few. This is evolving. It's not easy, but I think the day that we're able to take away the left atrial appendage, which is fairly easy from a small thoracotomy, do an AF ablation, do a lateral AD, maybe a second memory to the circumflex, then Bob's your uncle, right?
Yeah, Dr. Rule, thank you so much. I mean, I think you bring up a great point, and it's an approach that in components already exists, right? The same subxiphoid incision that you saw twice already this morning, once on the redo and once on Gianluca's case, you can put a cannula and introduce a unipolar suction device that allows you to ablate that whole posterior wall. So we don't typically think about that in combination with the CABG up front, but that absolutely exists already in the field. And so I agree with you 100%. We can combine forces, if you will, combine passions in order to provide AFib treatment, coronary treatment, and do it without sternotomy. 100%.
Good, yes.
Question, do you think cryoprob can be used in pump surgery? Because cryoprob is, you don't have to, because I use the cryoprob, it just goes transmural and use the cryoprob to how they can.
So I'm going to let Dr. Damiano answer that.
No, well, it's a good introduction to, at the end of the day, we have to be pretty data-driven here. And I'll make some comments, but first of all, just that comment. All present ablation devices are thermal, okay, whether cryo or radiofrequency. Epicardial thermal ablation is biophysically impossible on the beating heart. And it's been shown for 50 years. It's not possible even from any type of physical way, because the circulating intercavitary blood volume is a huge heat sink, and there's just no way to do it. And you can see the people in the beating heart, the problem with cryo, and also its advantage, like in many things in life, is that you have to use it endocardially. The nice thing endocardially is no fat, which is a huge problem for bipolar clamps and for epicardial cryo, but at least then you don't have it. But the disadvantage endocardially, right, is you have to be on bypass. It's very hard to, cryo is an impossible technology. It is possible catheter-based because you come from the inside out. Unfortunately, outside in with any thermal technology will be impossible if it's unidirectional. The advantage of the bipolar clamps always have been because you clamp, you get rid of that heat sink effect, right? But you're much more limited in lesion set to basically just a box. But that's the problem. Now, Richard mentioned pulse field ablation, which we're looking at, a lot of groups are looking at, is a non-thermal technology. So it has huge benefits potentially for surgical ablation, because it could be the first technology that epicardially it wouldn't be affected by the heat sink. The sobering aspect of that, despite it's a very cool technology, very quick, it has not shown any better results than RF in the catheter ablation world, and the results aren't very good. I'd like to make some comments, Armin, and also get your thing. First, I'd like to tell everybody, we still, at this point, 2025, we have no idea really the mechanism of AFib in any patient. I mean, we really don't. And what we've thought, these big reentrant circuits, they don't exist. We've been mapping patients for almost 40 years now. You never see a stable reentrant circuit. Triggers from the pulmonary veins, obviously important early, but in most of our patients probably don't play a huge role. And isolated PVI has not been very good for anything except early stage paroxysm, where it's really good. So I would say that every time we alter the traditional maze lesion set, and I think we need, and we have, and we've certainly in our center altered a lot, but I would urge everyone, you need to look at the data for it. And the data is still, the answer even for Encompass is still out, because really good data, we don't have large series. And the follow-up, you remember, for AFib ablation, any type of AFib ablation, is freedom from not only just all atrial tachyarrhythmias at a year, not at 30 days or discharge. 1 year and you should be off drugs. And I would say these trials that aren't reporting drug usage, antiarrhythmic drug usage in CABG patients who probably weren't on them before, that's not an appropriate way to report your results. And the problem, and even I'll say the problem even at our center, when we looked at our Encompass results, the great majority of my surgeons, even though we developed the maze, we introduced the maze 4, were as big a dedicated AFib center as you could find. The majority of my surgeons weren't following their patients at a year. And it makes the follow-up very difficult, and most surgeons aren't used to that. And if you expect your cardiologist, electrophysiologist to follow it, you're kidding yourself, because they don't even really follow their patients, but they're certainly not going to follow yours. So I would just argue that you need to follow the patients, and still the verdict is out. These could, and I am very excited about these attempts, and I thought all the comments were great, and I agree with Mark completely. We're missing huge opportunities, because we can even thoracoscopically get to the appendage. We can do a lot of work, and PFA may open up some really new frontiers in that. But we really have to be careful, because we're not sure of the mechanisms. And we introduced the maze 4. We were really the first group to show that you had to isolate the back of the whole back of the left atrium, where the Encompass developed, because we really thought at that time, we assumed we were arrogant enough to assume we maybe knew what caused AFib, because it was these big reentrant circuits. And if that's the case, you don't need to isolate the back of the left atrium. I mean, you don't. But we found when we introduced the maze 4, we cut our success rate at 5 years by 50% without that, but with all the other lesions. So, I think we're still waiting to see in what patients, at least in our center, the Encompass seems to work better in paroxysmal than certainly long-standing persistent. If you have a young patient who is symptomatic with his AFib, to lose the opportunity if you're coming in there and you've got the chest open to do a full maze, to me, is probably, I think there are patients where that should be done. So I have a couple questions for you with the Tampa 2. The one thing that bothers me, and I notice your cartoon didn't show it, which is the circumflex coronary artery, which the Tampa 2 lesion, I will give a note of caution to everyone here. That lesion, if you do it with the heart arrested, you're freezing the proximal circumflex. Now, if you eat, and I wouldn't do it beating, but first of all, in the late 70s, we showed that any type of freeze causes late intimal hyperplasia and coronary occlusion eventually. It takes years, so probably they won't blame you 3 years later when they get the big circumflex occlusion. And I guess maybe if you're bypassing, but do you worry about that? And, it's not this is the proximal circumflex. The reason the maze didn't put that lesion is because the circumflex sits there. And we've always tried in the beginning with the maze not to freeze coronaries. You really don't want to make a living doing that, because it's not going to end well. But what do I'm worried that they haven't really discussed that, and a lot of surgeons aren't thinking about it. Now, if you did it, you have to do it, obviously, with the heart arrested, but you could give pledge during that. But, one, do you worry about it, and do you do anything to prevent that?
So I think it's a great question. I think we haven't worried about it for the same reason that we typically don't worry about the right coronary if we're doing the right-sided lesions arrested. And
I would, though, if you do it arrested. That's why we always do it beating.
Okay.
It will freeze. And the right coronary is a little more protected than the circ from the inside the circ you could get. From the outside, from the inside, the right coronary sits more epicardially in fat. And usually it doesn't freeze, but you still could do it if you're arrested. And I would be worried about it.
Okay.
I would give pledge.
Okay.
Okay. Well, maybe we'll move on to the next talk. Thanks, Armin. Okay, our final talk in this session is Dr. David Caparelli from Luminous Heart Center in Annapolis, who will talk to us, what does normal sinus rhythm and minimal pain provide our patients? David.
Thank you, Dr. Damiano. It's a pleasure to be here today, and a little bit intimidating to be up on the stage with such giants in the field of arrhythmia surgery. But I just wanted to touch base sort of as a final talk on what we're actually achieving when we treat atrial fibrillation with ablation at the time of cardiac surgery. And then we're going to talk a little bit about pain control, and I want to make sure that we get to that. So obviously, everyone knows about the progression of disease from paroxysmal to persistent to long-standing, persistent, and permanent atrial fibrillation. So if you have the chest open in someone who has paroxysmal atrial fibrillation or persistent atrial fibrillation, we should be addressing that, and you'll see why in a moment. We know that there's an increased stroke, increased risk of dementia, significant heart failure associated with atrial fibrillation, which I don't think everybody appreciates. I think most people think of thromboembolic complications, but don't really think about the ramifications of heart failure. And a significant increase in mortality associated with patients who are left untreated with their atrial fibrillation. There's certainly annual costs associated with the treatment of atrial fibrillation or the lack of treatment. And this really gets to why we're in the symposium and why this is a huge talk. The majority of patients that go to open heart surgery through sternotomy are not receiving appropriate ablation. That is dramatic. If you look at this group of 100,000 patients, 77% received no treatment during their cardiac surgery, with only 10% of them actually being ablated and only 12.5% receiving left atrial appendage occlusion only. So while you're treating the thromboembolic potential with clipping the left atrial appendage, you're not doing anything for the atrial fibrillation in the majority of patients undergoing cardiac surgery in that period. Again, here we see that broken down into paroxysmal and non-paroxysmal atrial fibrillation, with the majority of patients, even with non-paroxysmal atrial fibrillation, only receiving left atrial appendage management, which is that single that Dr. Kankui referred to, but really leaving a lot of players on base and not getting the runs that we need to optimally take care of our patients. There is a misconception that the electrophysiologist will treat. So we'll get in, do our cabbage, do our valve, leave the atrial fibrillation for the electrophysiologist. And the fact is that once a patient has persistent or longstanding persistent atrial fibrillation, they're often not addressed by the electrophysiologist. Now, I think that PFA may change a little bit of that with the speed with which they feel that they can isolate the posterior wall, and I think the jury is out on that. But this is a misconception. And while this slide might be a little bit dated in the wake of what Dr. Damiano just talked about with macro reentrant circuits, just isolating the triggers in patients with long-standing persistent atrial fibrillation is not an adequate treatment. So we really have to be looking at the Cox-Maze-4 or variant of such in order to achieve the results that we wish. So what are we talking about here? We have touched on this, but there is substantial data to suggest that ablation with open heart surgery does not increase morbidity or perioperative risk. I think that is very important. Once you've learned these techniques as outlined by Dr. Kankui, as outlined by Dr. Cox and all of his disciples, myself being one of them, this can be done very safely in the operating room with not a lot of additional pump or bypass or clamp time. So what are we actually doing for our patients? Well, right off the bat, as was discussed in the first talk, we're reducing stroke risk, not only by eliminating where 90% of the strokes come from, which is the left atrial appendage, but also reestablishing sinus rhythm. There are small numbers of patients who have strokes despite adequate left atrial appendage management, but if you have restored sinus rhythm and treated the left atrial appendage, the stroke risk is extremely low. We're improving 1 month and 1 year survival rates. And survival at 2 years, once again, shows improved survival with adding AFib ablation to open heart surgery. Data from the Northern New England Cardiovascular Study Group shows improved long-term survival as well, out to 5 years in this study, and this was done quite a number of years ago, adding ablation to isolated CABG. And overall, again, a 20% increased survival at 10 years. I think that is something that we should be offering our patients. We can improve that survival in all categories with no increase in operative mortality or morbidity. So what is the risk of untreated AFib in cardiac surgery patients? We have increased risk of stroke. We have increased risk of mortality down the road, more heart failure and readmissions. Moreover, patients in sinus rhythm have better quality of life. Antiarrhythmic drugs are not well tolerated. Anticoagulants are not well tolerated. And a slide that Dr. Damiano referenced, you have to look at freedom from antiarrhythmic drugs as well. And you can see the long-term results of the COX-Maze-4 out to 10 years with a dramatic freedom from both atrial tachycardias as well as atrial tachycardias and antiarrhythmic drugs, which I think is really the cornerstone of the treatment of atrial fibrillation. So what are the 2017 guidelines? We're now going back almost 10 years with concomitant CABG. It's a class 1 recommendation. Clipping the left atrial appendage is also a class 1 recommendation that was updated in 2023. And if you compare that to other class 1 recommendations using the left internal mammary artery to the left anterior descending artery or treating severe symptomatic AS with aortic valve replacement, we are dramatically under-treating our patients with atrial fibrillation. I want to get on to the talk about a little bit of cryo, and I don't have much time left, and I apologize, so I will just skip over this, but these are basically the options for paroxysmal atrial fibrillation, but ultimately an encompassed box lesion or a COX-Maze-4 is the right answer for patients with asymptomatic atrial fibrillation. And again, COX-Maze-4 for persistent long-standing persistent atrial fibrillation is really the best answer. So what do we do by providing sinus rhythm to our patients? We're decreasing their risk of stroke. We're improving their quality of life. We're increasing long-term survival with no perioperative risk, no increased perioperative risk, and we're providing what's optimally based care based on best practice. Now, to speak very quickly about what is a new procedure for the treatment of postoperative pain. Obviously, opioids are a big deal to patients. There's a lot of awareness around that. And when we look at ERAS protocols, they say very clearly that we should use multimodal analgesic approaches to the intraoperative phase as well as the postoperative phase of care for the treatment of postoperative pain. If you look at the incidence of new persistent opioid use following cardiac surgery, 1 in 20 patients are still using opioids at 2 years. So this is a dramatic curve that if we can address this early, we can reduce the incidence of developing chronic pain and opioid dependence. This is really what we like to call transitional pain from 3 days when the patient's being close to discharge to 3 months. If patients are still taking narcotics 2 to 3 months later, they're going to have a long-term problem. If patients are taking opioids 5 days after surgery, they have twice the chance of developing an opioid dependence, and if they're out 14 days, 3 times. So what is cryo nerve block? Cryo nerve block is freezing the intercostal nerves. This temporarily blocks the pain signals to the brain for a period of approximately about 2 months. I'll discuss that in a second. Basically, by freezing to minus 60 degrees, we're disrupting the axon, but maintaining the nerve sheath so that the nerves can regenerate. I'll get through this. Again, I apologize that we're running a little late. There are 2 probes available right now. The Cryosphere Plus probe, which is an 8mm probe. We recommend intercostal cryo nerve ablation for 90 seconds using that probe and for 60 seconds per ablation for the Max probe, which is a 10mm probe. We begin the operation. We typically identify T1 through T7 bilaterally, freeze them for 1 minute, 3 to 5 centimeters from the mammary bed. Nerves grow back at about 1 millimeter a day, and therefore, if you're 6 to 7 centimeters from the sternotomy, you get about 60 to 70 days of pain control. And we obviously do this bilaterally. The whole procedure takes about 20 minutes. I can usually get the nerve block done and the mammary taken down before the vein or the radial artery are harvested. The cryo nerve block procedural technique, you need to maintain gentle pressure up against the neurovascular bundle. I do score the endothoracic fascia so that I can really get the probe into the intercostal space to ablate the neurovascular bundle. In this area of the chest, you do not really see the neurovascular bundle as you do more posteriorly in thoracic cases. Incomplete cryoablation will lead to pain that's worse than your sternotomy, so you have to abide by the technique. This is our current algorithm in over 300 patients that we've used in my new job in Annapolis, and I used it in 200 patients prior to that. We basically give 1 dose of IV Tylenol or per rectum Tylenol immediately coming out of the operating room. We do not give any narcotic as they're waking up. We extubate, and basically they're maintained on Tylenol and gabapentin throughout their hospital course, and we do not discharge anybody on narcotics. We have about half of our patients that are sternally plated and half of our patients that are only wired, and it works equally well in both situations. We use it in all sternotomy patients. We've used it in redos, valves, cabbages. It's ideal for opioid-dependent patients, but I wouldn't recommend those as your first trial of, to see if you have success. I'll just give 2 very quick examples, and then I'll open up for, yep. Okay, I'll go to one example. This is a 67-year-old gentleman who had a 3-vessel cabbage cryo nerve block. His chest tubes were discontinued on day 2. This is the morning of day 3, so less than 72 hours after surgery. Walking in the hallway like he had had nothing done, he went home this afternoon. He went home the afternoon of day 3 with no narcotics. I'll just skip over the fact that this can be considered part of a multimodality opioid-sparing pain management protocol, which is recommended by ERAS. And I will just say that we're reducing anxiety preoperatively because patients are more worried about their pain than they are about their heart in many cases. We're providing immediate pain relief with early extubation, shorter ICU times, minimal perioperative narcotic use, overall shorter length of stay, and most of our patients are being discharged on Tylenol only and coming back in 2 weeks ready to start cardiac rehab. Thank you.
Thanks, David. That was great. We are really out of time, but if anyone had a quick question, yeah, go ahead.
Thank you for the great presentation. Asking about the cryo-LP, it would be better than the causing illness for the patient or just for a short time?
So the pain control lasts for about 60 days. So the nerves grow back over 60 days. So they typically describe a box of numbness from their nipples inward and from the sternal notch to the xiphoid, no pain whatsoever until about 60 days they start to feel the midline again.
Okay, real quick.
Yeah, I can also take questions outside.
Yeah, Fraser Rubin's Auto Heart. A quick question. If you've taken the mammary on one side and then you do this ablation on that side, what's the effect on the sternal blood flow?
So there have been anecdotal stories of Dopplering the intercostals after freezing and the blood flow returns. We've not seen an increase in sternal wound infections. We've not seen an increase in dehiscences. So we typically, I'm not a bilateral mammary guy, but I freeze the right, I then freeze the left and take down the mammary. I've not had issues with sternal blood flow.
Okay, I think we're going to have to please, David's around afterwards if anyone wants to ask some stuff in the hallway, but thank you all for attending, and I'd like to thank all the speakers for great talks and Atricure for their support of this fantastic symposium. Have a nice rest of your day.